All right, so I'm going to be talking about preparing for the next generation family planning when you have NF. In my role as a genetic counselor at an NF clinic, I help families that are new to their diagnosis or have a possible diagnosis and part of the genetic workup and education around that. And another big part of my role is talking with patients and couples about preparing to possibly have children and how their NF does or does not play a role in that for that. So what is family planning? So family planning involves the decisions that we make about if, when, and how we add to our families. And traditionally that's thought about deciding to become a parent and to have children that are biologically related to you. But I also want to acknowledge that there's many different types of families and different ways that families can be made up. There's also a lot of different factors that play a role in family planning. There can be internal factors, like whether you have a partner or not, how you feel about being a parent, religious affiliations or beliefs that you have, things like time, money, housing security, things like the global climate and political environment. There's lots of things that play a role, and our medical conditions, our physical and our mental health also play a role in that. And NF can be a part of that decision making for our families that are affected by these conditions. So just talk about the different types of NF and what we know about them from a genetic perspective. So starting with NF type 1, we know that everyone that has a pathogenic variant or a mutation in the NF1 gene will develop symptoms of this condition. We know that there's a very large degree of variability within families, and that in most cases, our specific genetic mutation does not predict the severity or the types of symptoms that we'll see in an individual person. Now, there are some rare cases, about 10% of people, that do have particular mutations in their gene that is associated with a certain presentation. I've listed a couple of them here. If you've had genetic testing in the past or you're getting genetic testing done, you can always ask your provider, do I have one of these variants that's associated with a certain set of risks? Because that might change some of your decision-making around family planning. For NF2 related schwannomatosis, or what we used to call neurofibromatosis type 2, again, everyone that has a pathogenic variant does develop symptoms of these conditions. The severity, different from NF1, tends to be very similar within the same family. So the age of onset tends to be more kind of in line with other people in the family, with the exception of parents who are mosaic for NF, which I'll explain in a couple slides. People that are mosaic tend to have milder symptoms or a later age of onset than their children that are not mosaic. With NF2, your genetic test results actually are more likely to kind of predict the severity within the family, and that's dependent on where in the gene, whether it's at the beginning of the gene or the end of the gene, as well as a particular type of variant. So if you are affected with NF2 or your family is, you can talk to your providers about what does this tell us about the risks in my family. And then lastly, for the rarest type of NF, schwannomatosis, which right now is linked to 2 genes, LZTR1 and SMARCB1, and we think there's actually a couple more genes we haven't discovered. This one is different in that not everyone that carries a gene mutation will develop symptoms or develop tumors. We call this incomplete penetrance, which means you have a genetic risk factor, but you might not develop symptoms during your lifetime. And due to the rarity and the newness of our understanding of this condition, the exact risks of developing tumors, we're not entirely sure. It's a bit unclear. For this type of schwannomatosis, we don't have these links between certain variants and certain risks in terms of presentation, but we know it can be different within a family. And then I want to point out for anyone that's affected with schwannomatosis that's linked to the LZTR1 gene in particular, we do know that's linked to other conditions as well, particularly something called Noonan syndrome. So if you are or your family is affected by the LZTR1 gene mutations, talk to your provider about whether there's a risk of Noonan syndrome that you need to be aware of. That happens when someone inherits mutations from both of their parents in the same gene. So what is the risk of passing on NF? So for all of the types of NF and schwannomatosis, generally the risk of passing it on is 50% if we don't do any additional testing or any interventions and we conceive a child naturally. We call it autosomal dominant. Autosomal means that the sex of the parent and the sex of the child does not change the risk. So the risk is 50%, whether it's a mother or a father, whether it's being passed down to a daughter or a son, okay? We all have the NF1 gene, we all have the NF2 gene, we all have the other genes that cause schwannomatosis. Someone has this condition because they have a mutation that causes one of their copies of the gene to not work correctly, and that leads to the different symptoms of these conditions, okay? Sometimes though, the risk can be less than 50%. And that is because a large number of people that are what we call sporadic cases of NF or schwannomatosis, meaning that it's not in either of their parents, it's a brand new mutation that happened in them. Mosaicism can happen when the mutation happens after you were conceived. So it can happen very early in embryonic development, where a mutation happens in some of the cells as you're developing in the womb. And so you can follow the blue colored regions in this diagram. So as you're developing as an embryo and into a person after you're born, some of your body carries the mutation that causes NF, but other parts of your body do not. And sometimes this leads to milder symptoms than you would have had otherwise, because less of your body is at risk of developing things like the tumors that we see in NF. Okay, there can be some clues as to whether you have mosaic NF. So first of all, you have to be a sporadic case. Sometimes we see that you only have symptoms on one part of your body, like on the left side or the right side, or you have patches of cafe au lait spots or freckling only in one armpit and not the other. Sometimes we learn someone is mosaic because of their genetic testing results. So we expect that when we test the blood sample, that we find the mutation in half of the sample, because half of your DNA have it, half of it does not. But sometimes the blood sample comes back with very low levels of the mutation, which can be a clue. Sometimes we can't find the mutation in a blood sample at all. And so we have to directly test things that are related to NF, such as directly doing genetic testing on cafe au lait spots using a skin biopsy, or directly testing different tumors. So sometimes if you've had surgery, we will send a piece of that tumor for genetic testing to help find your mutation, okay? The thing about being mosaic is if you do happen to carry that mutation in the cells that are passed down to your children, so if it is in your egg cells or your sperm cells, then if that child is born with NF, they are no longer mosaic. They will have it in all of their body, which can change their health risks, okay? NF is unique from other genetic conditions in that the rate of being mosaic is much higher than other types of conditions, and this can actually impact family planning quite significantly. So when I think about what are the family planning options that are available to someone with NF, I generally try to think about them into two main categories: choosing to have children that have a genetic relationship to you, then thus have a risk of NF, and how are we mitigating that risk if you want to, and then choosing to have children that are not genetically related to you. So when we think about not having children that have a genetic relationship to yourself, we have things like choosing not to have children, choosing to adopt or foster children, choosing to use a sperm or an egg donor in place of your own sperm or egg that has the genetic risk. And then for same-sex couples, choosing to use the sperm or egg from your partner rather than yourself. When we think of the options for choosing to have children that have a genetic relationship to you, we can evaluate children after they are born if we know they have a risk of NF. We can test during pregnancy, and then we can also do testing as part of in vitro fertilization by testing embryos. And I'm going to focus on choosing to have children that have a genetic relationship to yourself and kind of how we approach that genetic risk. So first of all, we can evaluate children after they're born. This can be done whether or not we've already done genetic testing in the parent and we know their mutation. If we do have genetic test results from the parent, it's very straightforward to do genetic testing in children and get a yes or no answer. Does your child have the NF1 or NF2 or schwannomatosis mutation or not? But we can also do clinical evaluations. And the timing kind of depends on what type of NF we're talking about. So for NF type 1, most children that are born from a parent that have NF1 will develop cafe au lait spots and freckles at a pretty young age. And so we can tell when they're babies if they have NF or not clinically, and we usually don't need genetic testing as part of that. For NF2 related schwannomatosis, we're concerned about tumors growing at a little bit of an older age, and we don't have those outward signs. Generally, we talk about doing things like an MRI to look for tumors in the brain and spine starting about age 10, if a child's at risk of NF2, but we might do other things at a younger age, like an eye exam or seeing a neurologist. There are exceptions to this general rule of starting at age 10 for MRIs, because there are some families where the risk of developing these tumors is at a younger age. So we might start those at a younger age than 10. And then for the other types of schwannomatosis, we're usually talking about symptoms developing in the teen years or the adult years. So we generally start those evaluations around that time. So it really depends on what type of NF risk are we talking about for the timing of this. So we can also test for NF during a pregnancy. That requires that we know the mutation for the parent, so we know exactly what is causing NF for that family. This is an invasive type of testing that does carry some risks of complications, because we do have to test either a piece of the placenta from the pregnancy or some of the amniotic fluid from around the fetus to see if their mutation is there or not. It does take a couple weeks to get the test results back. Generally, this type of procedure and testing is covered by insurance. And there's a couple of reasons why someone might choose to test while they're pregnant. Some people choose this option because they are interested in terminating a pregnancy that is affected by NF, which is a very difficult decision to face. Also something that many people in this country don't have access to because of the timing that these procedures have to happen. The earliest that you can do this type of testing is at the end of your first trimester. Some people also do this because they want to be prepared for the birth of a child that might have NF, and the uncertainty of the genetic status during pregnancy is causing a lot of stress for them. So they do this testing even if termination is not something they are considering, but they want to know with more certainty that will my child have NF or not. The third option that we have available for having children with a genetic relationship to you that we can use with the risk of NF is conceiving with a fertility clinic using something called in vitro fertilization, or IVF, and pre-implantation genetic testing, or PGT, which means testing an embryo. So after the sperm and egg come together and we have fertilization, testing the embryo before it's implanted in the womb for pregnancy. We do need to have generally genetic test results from the person that has NF in order to do this. It is a long process with many invasive tests and procedures, and many times insurance coverage can be limited for these procedures. There are two main types of PGT that are used on embryos. The first one is PGT-M, which stands for monogenic or single gene. And this is the type of testing that is done to test for NF mutations. It's also used for other types of genetic conditions as well. There's another type of PGT that's often done in IVF now called PGT-A, and that stands for aneuploidy, which is a reference to the chromosomes that we have. And what that does is it tests to see, do we have the correct number of chromosomes in each of these embryos? Because we know that that is something that's really common is a cause of early miscarriage. So checking the chromosomes to make sure they have the correct number is something that's helpful to make IVF more successful when you do a transfer. So usually we do both. IVF is long and IVF is complex. There's a lot that's involved and it takes a lot of time. So when we think about what is involved, you have to meet with the fertility clinic doctors, you have to have different tests done to see, are there any challenges that will occur with trying to conceive? You need to actually make a special, what we call a probe, a unique test for your NF mutation as part of this process, and that can take several months because it's custom made. You need to collect the eggs from the female partner by stimulating the ovaries and going through a procedure to collect them. You need to collect the sperm from the male partner, go through fertilization. Then they let the embryos grow for about 7 days, where they're only a couple hundred cells in size, and they take a couple of those cells out for the PGT. Then you have to wait for the PGT results, and the embryos are actually frozen while you wait for that because you don't want them to continue to grow. And then once we have the results, we review them, and if there is an embryo that is negative for the NF mutation and has the correct number of chromosomes, then that embryo is then thawed and transferred to the womb for pregnancy, okay? And that's a description of it in a very linear way, but it doesn't actually always go so simply. Sometimes you don't get the correct number of eggs to do the testing. You only get 1 or 2, or maybe they're not good quality. Sometimes you get to the point where you're going to be testing the embryos, but the embryos didn't grow very well and you have to go and collect more eggs. Sometimes you don't get the genetic test results you were hoping for. Sometimes you don't become pregnant after a transfer. So I have patients that go through what we call cycles of IVF, collecting more eggs, doing more testing, and it can add months, sometimes years to the IVF process. So it's not so simple to just go and do IVF. And when we do IVF, there's not a guarantee we'll get a pregnancy, and there's not a guarantee we'll get a baby at the end of this process. So this is an example from one of my patients who they started with 25 embryos. They had to do 3 retrievals to collect eggs to get to 25, and 10 of those embryos did not grow. So they had 15 embryos available for the genetic testing. And they checked for their NF1 mutation and they checked for their chromosomes. And when they got the test results back, I have here in red, the ones that were either positive for the mutation or didn't have the correct number of chromosomes. And then in green, they only had a single embryo of the 15 that had the genetic test results that they were looking for a transfer. Okay, so sometimes this does happen. Sometimes we get the opposite and you get many eggs and many embryos and many that have the result you're looking for, but it's hard to predict where this will go. So I want to talk a little bit about what is PGT and how is this custom test done. It's going to get a little bit complicated, but there's 2 ways that we can do it. One way is something called linkage, which is commonly done if you have a familial case of NF. I'm going to use NF1 as an example. So you guys have heard of things like you do like crime scene investigation and you find out someone is related to someone else, or you do 23andMe and you have ancestry testing. This is all DNA fingerprinting that is looking at little genetic changes on our chromosomes that are different between different people. And so when you have a familial case of a genetic condition, what they do is, say you have NF1 and your parent has NF1. They take genetic samples from all 3 of you, and they know that these little genetic markers, I've used the numbers and the letters to illustrate. And what they do is they say, okay, well, you have 1, 2, 3, and DEF on your chromosome 17 for NF1. And then we know you have DEF and your mother also has DEF and both of you have NF1. Therefore, we know that chromosome 17 with that genetic fingerprint on it is carrying the mutation. So it's a very indirect way of linking the genetic condition to the person. We're not looking directly at the gene. We're not looking directly at the mutation. We're linking it to the chromosome, okay? And so then when they do the genetic testing on the embryos, they just looked to find this particular DEF chromosome, and that tells us that embryo has NF, okay? So it's most simply done if you have a familial case. It can also be done if you have a sporadic case of NF, but it's a little bit more complicated to do it. Sometimes we can do it if you've had at least 1 child or 1 pregnancy that we know the genetic status of, and then we're able to collect all the samples and link it to the chromosome. Sometimes we can do it in the individual embryos if we have enough. Okay, so that's the indirect way that we can do PGT for IVF. There's also something that's called direct PGT. So rather than linking to the chromosome, it actually, what they do is they take a DNA sample from the patient with NF that's planning to do IVF. They take just a couple cells from the sample, because when we test an embryo, we're only taking a couple cells because there's not that many cells in an embryo to start with. And they do this specialty genetic testing that says, okay, if we only look at a couple cells at a time, can we detect the variant or not? Will we pick it up in this very, very small sample? And if they're able to detect in this very small sample, then they can do this direct type of PGT. This is a specialty test that's only available at a few laboratories in the country. I've listed a couple of them here. Genetics in particular will take some of the most challenging cases. So it's something that you really need to talk with your IVF clinic about if you have a sporadic case of NF, if this type of PGT is possible. There are different challenges to doing IVF and PGT. If we're looking at things like the linkage type of PGT probes, if you have a familial case of NF, but your parent that has NF has passed away, or your other parent has passed away, or you're not in contact with them, then that's challenging because you need their genetic samples to do this type of PGT. If you have a sporadic case of NF and you're trying to do the linkage type, it depends on how many embryos you have to work with. It also depends on whether or not you've had a child before or pregnancy before, if you're able to do this type. If you're doing the direct type of PGT testing, it depends if you can detect your particular genetic variant, which most people with NF, we can find your mutation when we do testing, but there are some people that we cannot with the testing that we have available. We also know that the direct type of testing works well for certain types of mutations in the gene and less well for other types. And so that can impact the success rates. And then if you have a mosaic type of NF, it can also be a little bit more challenging to do this because we need a sample that has your mutation. So I have a patient with mosaic NF2 who is using the direct method for PGT, and we had to find a sample of DNA from one of her tumors to send to the PGT laboratory so that they could work on this testing for her. So I have a couple tips about kind of if you're thinking about family planning or down the road, kind of things, food for thought as part of that process. One is to really talk through on your own, as well as with people that are important to you, like your partner, your family, your healthcare providers, about what are your family planning options and how you feel about them. So considering your values, what types of resources you have, the health of yourself and the potential health of your future children. I think walking through each option step by step, what do I think I would do when I got here, can be helpful, as well as writing things down and really starting this process and thinking about for yourself, what do you feel is most important and what do you want to try to do? What would you like to do? I also recommend that if you are considering options that might require genetic testing in yourself, that you do this sooner rather than later. Generally, I say, think about this 2 years, maybe even more, before that time that you would like to have children. Because some genetic testing takes time, particularly if you have a mosaic case of NF, we might have to send specialty testing, like the skin biopsy testing can take over 6 months to get test results back. Tumor testing can take some time as well. So you want to make sure that if you are reaching a place where you need that genetic test result, that you've already gotten it ready to go. So I say, just do it whenever you're doing like a follow-up appointment with your doctor to get that ready. Also, one thing to consider for men that have a mosaic case of NF, there is a specialty type of test that we can do. We can do genetic testing directly on sperm samples, and that actually gives us a precise risk of passing on the mutation to your future children. Because we have some people, men with mosaic NF, I have had testing done on their sperm samples, and the risk to pass on to their children is actually a lot lower than we thought. Unfortunately, it's something that's not available to women that have mosaic NF. It's not something that we can do to test eggs, but we can do it for males. Some of this testing is also expensive and not covered by insurance, so you need to plan ahead for that as well. I've listed the University of Alabama Genomics Laboratory. They're the lab that does some of this specialty testing on sperm samples, tumor samples, skin samples in this country. Another thing to consider is if you do have a familial case of NF and the option of IVF and PGT is something that you are considering, some people might want to talk to their parents about banking DNA samples in the event that something might happen, their parents are not available in the future or they pass away. That way you have their DNA banked and saved for you, so you can use that linkage type of PGT that is a lot simpler to go through than the direct type of PGT. And then I also want to acknowledge IVF is expensive and not in many cases covered by insurance very well. And so I'm thinking about preparing financially if IVF is something that you're interested in. I recommend that everyone research their insurance coverage options, particularly if you have an employer that has multiple insurance tiers. Sometimes the coverage for fertility treatment is different if it's a higher tier plan, for example. I recommend that you call your insurance provider and ask them things like, how do I qualify for IVF? Do I have to have done something beforehand before I can do this? What types of things do you cover and do you not cover? So you can have a better sense of what your insurance coverage is. Also asking if there's a maximum that they cover for IVF. And then estimating costs. I put some general cost estimates on here. It can differ from different parts of the country. But we're generally talking about over $10,000 per cycle. And a cycle is defined as one egg retrieval and all of the procedures that are involved with it. The genetic testing is an additional cost on top of that. So it can become quite expensive quite quickly. And then sitting down and creating a financial plan about how are you going to pay for things that are not covered by insurance. There are some organizations, we have some regional ones in the Northeast that can help with some costs. There are some national ones, but looking at how are you going to have a savings plan to cover this if you're considering it. And then I want to just touch on maternal health during pregnancy and delivery, what we know and do not know. No pregnancy, no delivery is ever going to be 100% safe. There are always risks to delivering a child. Most people do not have any severe medical complications during pregnancy or delivery when they have NF. For women that are considering becoming pregnant, your health before pregnancy can play a role. So if you do have tumors in the brain or the spine that are being monitored, if you have high blood pressure or you have blood vessel diseases or scoliosis, those are just some examples of things that could potentially impact things and something to talk to your doctor about before you become pregnant if you're worried about them. There have been some population studies that have looked at, is anything different between women with NF1 that are pregnant and women without NF1? One large population study in Finland, which Finland is also only 5 million people, so large for them, but small for America, found that women with NF1 deliver their pregnancies a little bit sooner than other women. But by sooner, I mean a couple days sooner. So not that you're having preterm pregnancies. They saw that they had C-sections a little bit more often than vaginal deliveries, but they weren't entirely sure why. And they also saw that women with NF1 have less epidurals, the spinal tap, during delivery. And this is something that I have seen in my own practice. There is a bit of a disconnect between the recommendations of OBGYNs about what to do about a woman with NF and an epidural and NF providers. So I do have patients that have been denied an epidural because there was a concern they had a spinal tumor and that the epidural might touch the tumor. I have other patients that were only able to have an epidural after doing an MRI. Some of them had to do that MRI while they were in labor. So there is a disconnect. Generally, from our perspective, we don't think that that's necessary before you have an epidural, but these other providers disagree. So there needs to be more research and a change to those guidelines. There's also the question of, do my neurofibromas change during pregnancy? Do the hormones change my neurofibromas? And there's a lot of debate in the literature and in the community about that. Some of my patients have told me that they feel that they get more neurofibromas on their skin during pregnancy and after pregnancy, and some don't notice that difference. And there have been some studies that haven't found a significant difference between the two. And it's also something that's hard to study. The amount of neurofibromas and how quickly they develop on your skin is very different from person to person. And we can't clone a person and then follow them when they're pregnant and they're not pregnant and compare the two. We also don't really have great ways of monitoring neurofibromas on the skin in a way that's accurate. MRIs are not a good way to do it. There are some types of photography studies that are trying to figure out how we can very accurately monitor those, but it's a hard thing to watch. So there's debate about whether there is a true impact or not, or if those would have developed regardless if you had been pregnant during that same time period. I think we also have to acknowledge that pregnancy is a time where you spend a lot more attention on your body. So something that you might not have noticed otherwise, you're watching your skin a lot more closely during that time. So it's an unanswered question, but we do know that dermal neurofibromas are not dangerous, okay? Lastly, I just want to touch about my ongoing study that's also in your folders. So I'm really interested in how people feel about their family planning and what different things influence decision-making and how we can better help people with their family planning decisions. And there's been very little research on this in the past. So I did a pilot study last year within our clinic because the last time they had studied family planning perspectives in NF1 had been 1990, and I think we were overdue. So this is just a brief summary from our clinic. So we had 50 people complete a survey, a mix of men and women, most of which had sporadic cases of NF, particularly mosaic NF1. Most were non-Hispanic white, had a college degree or higher, but we also had a mix of perspectives. And then we also had a mix of different family planning statuses. So people that didn't have children, did have children, were planning on having children, were not planning on having children. Most of them were a little bit on the younger age, given this type of survey, but we had some older respondents as well. And I asked them, given your NF1, and the different family planning options that are available, which ones are you most interested in? Which ones are you least interested? And I'll highlight the ones that were ones that they preferred the most, which were choosing to have less children than they would have if they did not have NF. Choosing to do IVF and that pre-implantation testing, and then choosing to test during pregnancy, not for the purposes of a termination of pregnancy, but actually just to prepare for the possibility of a child with NF and remove that question. And then I also asked, so given what you would prefer to do, what have you done in the past for your family planning? And there was a disconnect between the two. So the thing that most commonly had occurred in the past was choosing not to have children, even though they would have preferred to have children otherwise. There were also a few people that did things like PGT, and a few people that their NF1 didn't impact their family planning at all. And then I also asked, tell me more about what's going through your mind when you think about how your NF impacts your family planning. And there were a couple different themes that have arisen so far. One is your own experience living with NF. So either having more significant medical problems and being concerned that the same thing would happen to your child. And then the opposite, saying that, I don't have that many medical problems, but there's so much uncertainty about what could happen. And the thought of having a child that has more medical issues than myself has impacted my decision-making. A lot about how uncertain NF1 is and how hard it is to predict what might happen if your child is born with it. As well as a few people that mentioned the cost of things like IVF and how that impacts their ability to use that particular option. And then a couple other themes. Many of our women that completed the survey were concerned about what would happen when I'm pregnant. Is there anything that could be serious that would happen to myself? Will I get more neurofibromas? Which, as I touched on, is a bit of an unanswered question in terms of, I can't give you a really precise risk that there might be differences in your health. And then also people mentioned different things about their mental health and how challenging this was when they think about, thank you. I'm near the end anyways. And kind of how this is a really difficult choice to go through. And I want to learn more from people that are not patients of our clinic. So I do have this open nationally for anyone who is an adult who has a diagnosis of NF1. I just want to hear from you guys about how you feel about family planning, because I think it's helpful for us as healthcare providers to understand what's going into some of your decision-making. Every person is unique at the end of the day. And my approach is always, let's talk about what you want and what you would like to do. But I want to see if there's maybe other things that we can do to provide better resources that align with what people are looking for in their family planning. So this QR code is in your handouts, is also up here if you wanted to snap a quick photo of it. And we're going to be collecting until the fall. So thank you very much. Anyone have any questions?
There's 2 online here, 3 now. I don't know if we have time for all 3, but okay. The first one is, if starting radiation prior to family planning, is there anything I should ask my provider before starting my treatment? Could the type of radiation or the location of radiation affect my ability to have children?
So that's a really great question. It depends, and I'm not a doctor, so let me put that disclaimer on there. But generally, when we think about radiation risks, we think about what part of the body is being radiated. Definitely, anytime you start any type of tumor treatment or cancer treatment, it's really great to talk to your doctors about what your family planning preferences are and when. Things like chemotherapy, we know, can impact fertility. So some people might want to do things like collect sperm or collect egg samples before they start chemotherapy for cancer treatment. We also know that certain types of drugs can carry a risk to a fetus if you take them when you're pregnant, or can carry risks to the sperm or the egg. So some people do things like collect those samples before they start certain types of medications. So I think if you have concerns about the risk to children, then talk about that before you start treatment. Yes.
Okay, thank you. I'm going to go with the second question here. For patients with LZTR1 related schwannomatosis, you mentioned the risk of Noonan syndrome if the other partner also has an LZTR1 variant. If someone was pregnant and the other partner had not been tested before, would a CVS or an amnio be able to test between Noonan's and schwannomatosis variant in the embryo?
Good question. So when we do pregnancy testing, we need to know exactly what mutation that we're looking for, regardless of what type of NF we're talking about. So for the LZTR1 type of schwannomatosis, if we want to assess if a pregnancy is at risk, we first need to test the other partner to see if they have a mutation. We do know that LZTR1 mutations are rare. So generally the risk of having a child with Noonan syndrome when you have this type of schwannomatosis is low. There's only been a couple of reported cases in the literature so far. But doing partner testing for LZTR1 can be done very simply and can take only 2 weeks, 3 weeks to get results back. And then only if they are proven to be a carrier of a mutation do you test the pregnancy.
It looks like this is the last one. Do people who inherit NF from a parent tend to have a more serious case than those who develop it spontaneously?
So for NF1, there is no correlation that we have seen between if you're a familial case or not. In NF2, you tend to have a similar presentation to your parent. The one exception to this rule is if your parent has a mosaic type of NF, then they might have milder symptoms because the mutation is in less parts of their body. There are some people that have mosaic NF that don't even know that they had it until their child was diagnosed. So if there is mosaicism in the parent, then yes, it can be different. But if there is not mosaicism, we don't see that association.
Thank you very much.
Are there any questions from the live audience? Yes.
I know you said 2 years before is when you recommend.
Yeah.
I mean, do you see mostly 20, 30s, or would you recommend being on top of it like a team?
So you are many times on your parents' insurance until you are 26. So that might be a good time to get genetic testing. They might have better insurance coverage than you do when you first get your first insurance plan. Many of my patients come to me and ask these questions and talk about this because they are with a partner that they are planning on having children with. So I have a lot of conversations with engaged couples and newly married couples, but you can definitely start this process younger. I have had 18-year-olds that say, Kara, I want to talk about family planning. And I say, great, let's do it. Do you want to do your genetic testing now and we'll hold on to it until you need it? And they say yes. So it depends on the person. But many times people think about it when they've reached that point where they have a person that they're planning on having children with. We talk about it together. Time is up. You can ask me at the break.